Welcome, everyone. Rush University Medical Center Renal Biopsy Conference for July 11th, 2024. Our picture showing right now we've got three new fellows we'd like to welcome into our fellowship: Dr. Chowdhury, Hussain, and Mumtaz. They will have 6 months of freedom before they get on the wheel to start reading the pathology. So they're smiling now, but if you probably saw their faces, they're terrified. But I promise we'll prepare them so they won't have to be so worried when the time comes. We've got a good case today. Our CME code is 491821. This is being recorded. If anybody is not on our mailing list, I see a couple new names here today. If you're not on our mailing list, send us a message here and we'll put you on the mailing list. All of these are being recorded and uploaded to our YouTube channel, which is readily available in Rush Renal Biopsy Conference. You can search and find our channel. We're getting close to 100 up there now. We do preserve patient privacy by changing their names and a few of the important aspects to protect their total confidentiality. We have nothing to disclose as usual. This is Dr. Gashti's case. I think I'll hand it over to Casey. You want to tell us about the patient?
Yes. The patient is 57, is a male. He has history of hyperlipidemia and GERD. He's got G6PD deficiency. He initially went to his primary care doctor for just a routine annual checkup. He wasn't really having any particular complaints, and his routine lab work showed that his creatinine was elevated to 2.2 milligrams per deciliter, and 9 months prior to that value, his creatinine was 1.1. So the primary order is a urinalysis, which was totally normal, no blood protein casts or cells. She also got a renal ultrasound, which showed echogenic kidneys, 11.5 and 12.1 centimeter kidneys, but no other abnormalities. So she couldn't figure it out, so she essentially referred the patient to a nephrologist who saw the patient about a month after the initial referral, and by now his serum creatinine is up to 3.3. His urine was repeated. It was still pretty bland. Blood pressure was elevated to 150 over 100. Patient denied feeling poorly, being ill. He has a job that requires being very physically active, and he hasn't slowed down. He's lost some weight, but that he attributes that to intermittent fasting, so intentional reasons for weight loss. He doesn't take any NSAIDs or herbal meds, and further labs were ordered. And because of the unknown nature of his creatinine elevation and AKI, he was set up for a renal biopsy while we were waiting for some of the labs to come back. Past medical history, as I mentioned, hyperlipidemia and GERD. He had hemorrhoidectomy about a year ago. He's a non-smoker, vapor, drinks socially, occasional marijuana, no family history that was relevant. He only takes a multivitamin. Even though his cholesterol is a little bit high, he's not on a statin. He's not on any other medications. He takes Zantac as needed for his reflux. He has no allergies. On exam, as I mentioned, he was hypertensive. He weighs 180 pounds with a BMI of 25. Physical exam was pretty unremarkable. He's an African-American gentleman, non-toxic appearing, good overall physical shape. His exam is normal, no edema or anything like that. So normal neuro exam, normal skin. Data that we got back after repeating all the labs: sodium 142, potassium 3.8, chloride 110, bicarb 23, BUN and creatinine 40 and 3.4, glucose 95, total protein of 9.5, albumin of 3.8, calcium 9.8 corrected, T-bili of 0.5, alk phos, AST, ALT were normal. His white blood cell count was 4.9 with a normal diff. Hemoglobin 8.4 and platelet count of 183. His ANA, ANCA, anti-GBM, Hep B, Hep C, HIV were all negative. Anti-double-stranded DNA was 1, and C3 and C4 were normal. His SPEP showed a paraprotein in the gamma region, and the immunofixation showed a monoclonal IgA kappa with quantification at the level of 1.5 grams per deciliter. Serum-free light chain showed a kappa of 42.4 with a lambda of 0.8 with a ratio of 49. Quantitative immunoglobulins, IgG level was low at 480. IgA was quite elevated at 2000. IgM was also low at 25. His urinalysis was yellow, clear, specific gravity of 1010, pH of 6.5, negative for protein, blood, ketones, or glucose, with no WBCs or red cells, no casts or crystals. His urine albumin to creatinine ratio was 33 milligrams per gram. His protein to creatinine ratio was 319 milligrams per gram. He underwent a 24-hour urine collection for urine electrophoresis, 2.4 liters of urine volume. Total protein was 15 milligrams per deciliter, 40% albumin, and paraprotein also detected. Same monoclonal IgA kappa that was detected in the blood was also detected in the urine. His ultrasound, as I mentioned before, normal sized kidneys, but increased echogenicity with no hydronephrosis. So this is kind of where we stop.
Yeah, so before we discuss the case, I want to throw this out to everybody. This is our poll number. We have one poll today. Which would you do first? Would you do a renal biopsy, a bone marrow, or it really doesn't matter, you need both? See if we can get a good representation here in the voting.
Pretty good response. A few more.
A couple more.
There we go. We can end it there.
And so we've got about half the people say we should start with a bone marrow biopsy, and the second is renal biopsy at 31% think that should be first, and that 20% says it doesn't really matter, you need them both. So we're going to come back to that, but before we get to that topic, I want to ask Dr. Corbett to discuss the case and the differential diagnosis and what do you think what do you think's going on? Steve?
Yeah, thanks.
This is your topic. You've written on these.
Yeah, but this is so strange. It's not even funny, right?
I don't know. You tell us.
I'm
That's why
telling
I
you
asked
now. Are you going to let me finish?
No.
Welcome to the new fellows. Well, it's like the E on the eye chart. There's no way you can ignore a kappa lambda ratio that high, and IgA kappa with an elevated IgA and reduced IgM and it's in the reduced IgG and IgM. I mean, this looks like a paraprotein associated renal disease, no matter what. I mean, I'm sure there's going to be something strange here before it's over with. As I was listening to it, originally I kept thinking, well, maybe this person has some sort of autosomal dominant tubular interstitial kidney disease. There's no protein in the urine, bland urine sediment, and he's got some progressive renal disease. But that clearly kind of goes out the window when you come back with all this abnormalities with paraproteins. But the problem I have is, if this would have been Hispanic male, I would have, again, without the paraproteins, I would have said, well, maybe this is an ALK2 amyloid or something, which is mostly it's tubular interstitial disease as well. But that's not the case here. What doesn't make sense to me, I would have said, well, this could be cast nephropathy, developing renal failure fairly quickly, bland urine dipstick for proteins negative, but then you would have expected, which is not unreasonable, because it would be all light chains, which wouldn't cross-react with the dipstick, because that picks up negatively charged albumin. But lo and behold, there's only 300 and some milligram per gram, 319 milligram of total protein. Now, granted, it's more than the albumin, which is almost normal, but it's not what I would have expected it to be. But I guess it's still above normal. I mean, normal goes up to around 200. So I guess cast nephropathy would be one of the first things I would think of associated with paraprotein. For it to be amyloid or light chain deposition disease, I would have expected a lot more proteinuria and a lot more albuminuria. Proximal tubulopathy, a Fanconi's-like syndrome with the bicarb is normal. So, I mean, I can't really, I guess it's possible, but I'm not really high on that. And then the question is whether it could be one of these paraprotein-associated crystallopathies in the kidney. I truly am kind of at a loss here. I think that's going to be, and I agree with people that might have picked number 3. I'd do a bone marrow and a kidney biopsy. I know it's a long shot, but I'm going to say this person's going to have some sort of, some sort of cast nephropathy. And like I say, I know it's a long shot because you would have expected a lot more light chain proteinuria than just 300 and some milligrams. But I'm going to end there and let someone who's smarter at this than I am give their differential.
Well, I don't think that's fair to yourself at all. But
No, I'm like I said, I can't wait to see what the biopsy shows.
yeah, so before I do want to get back to this, what will you do first? But I want to continue this discussion a little bit about the differential diagnosis. Dr. Rubin, you had commented in the chat. There's multiple teaching points here. You want to just spell them out for us, Mario?
Sure. I mean, this is obviously mainly directed at trainees. Look at the globulin gap that this patient has with an elevated total protein and almost a normal albumin. That's a hint that something is going on in the paraprotein area. Then look at the fractions, high IgA, low IgG, low IgM, as Steve pointed out. And this is one of the teaching points from Dr. Robert Kyle, how to differentiate an MGAS from a myeloma. In an MGAS, the other 2 fractions are not depressed. So when you have this kind of picture, then this is suggestive of a myeloma, which in this case is likely to be an IgA. And lastly is what Steve again pointed out, the dipstick is negative because it only detects albumin. And then when you look at the UPCR and the ACR, there is a gap, which then is documented to be an overflow proteinuria in the 24-hour urine collection. So great teaching points.
You know what? While you're at it, you might want to let them know who Robert Kyle is, because I'm sure a lot of the younger people have no clue.
Well, I think that Dr. Robert Kyle is considered to be the father of myeloma, these proteinemic disorders. He's at the Mayo Clinic in Rochester. And there are 2 classical papers of his. One is amyloidosis, and the other is on MGAS. So they are must-read papers.
Yep.
Yeah, I want to make, since we're talking about teaching points, one of the things that we often see, or maybe only shows up on the boards, is that sometimes you'll have a low anion gap with multiple myeloma because the immunoglobulin is positively charged and it's unmeasured cation. What's interesting though is IgA is negatively charged. So when you have an IgA myeloma, you would not see a lowered anion gap as you might see with the others. It is kind of interesting along those lines because the gap, I believe, is normal, and yet the total protein is pretty high here. It's not a little bit high; it's pretty high.
Well, while you're at it, what about the sodium?
Well, you could do anything. I mean, you could have pseudohyponatremia. I don't know that you'd get pseudohyponatremia with a total protein of 9.8, but you really need a much higher protein. But yeah.
Let me ask you a question. For the old timers, we encountered a pseudohyponatremia in the days when we used flame photometry.
That's right.
Now that they use ion selective electrodes, I think that piece, although interesting, I think belongs in a museum.
No, that's right.
But I mean, just for the trainees, that's another excellent teaching point from Dr. Colbert that needs to be kept in mind.
I'm not sure that the routine CMP machine or BMP machine is ion selective. I really don't think so. But
I don't think ours is, because we've seen some pseudo cases.
Yeah.
We
still have to ask for it.
Yeah, some of our centers, some outpatients are, some of the inpatient sides aren't. But yeah.
Yeah, and also it's brought up, occasionally you can get a pseudo hypobicarbonademia with paraproteinemia. That's been described. But since we're on these little pearls here, so Steve's saying cast nephropathy. Mario, what do you think it's going to be?
No, I mean, I think Steve is right on the money. I mean, the other thing to add is light chain nephropathy, which is a form of glomerular disease. He also mentioned amyloidosis, and the proximal crystallopathies were already mentioned. Sorry, here in Houston, we have alarms all the time. That's all I can add. Yeah.
Dr. Reen, what do you think this pathology is going to show?
Oh, it can be any one of the things which mentioned before. So let me bet on cash nephropathy.
So let's get back to the poll. The poll was, what would you do first, a renal biopsy, a bone marrow biopsy, or it doesn't matter, you need both? Dr. Corbett thinks that we need both. Steve, you want to support that?
Well, the renal biopsy will make the diagnosis, and and if he does have cash nephropathy, I would assume for the hematologist that alone would be adequate to make the diagnosis really of myeloma. I just think that they will probably, we talk about this all the time. We back into a lot of these paraprotein diagnoses by doing the renal biopsy, and that oftentimes can be enough. I just have a feeling that the bone marrow biopsy is going to be helpful as well, just to give them some sort of insight into how widespread plasma cells are and, how restricted they are. But, the renal biopsy may in and of itself be good enough. But I personally would have done, it's in this case, I think you've got to do a renal biopsy anyway, or at least I would, because I'd want to see how much acute versus chronic damage there is to get some sort of sense of what to expect. So that again, that may be enough, but I would have definitely done that. I think that both will I think that they will end up doing both, and I would agree with that. I know I'm kind of waffling here, but.
Mario, do you agree? Do you need both?
Yes, I agree with Steve. And although the bone marrow may be negative, this is another pearl from Dr. Kyle, because myeloma is a focal process, so you may miss it. It also, the number of plasma cells present in the marrow can be used as a myeloma burden, besides the level of beta-2 microglobulin, which is bound to be high because of the renal failure. So in a nutshell, yes. And also nowadays, in situ hybridization is an important method to further characterize the molecular biology of these proteinemic states, which a kidney biopsy is not going to tell you.
So I don't think there's any question the patient's going to have a bone marrow biopsy, because ultimately this either is I suppose, let's just say we did a renal biopsy first and you saw membranous. You're still going to have to do a bone marrow biopsy because he's got this paraproteinemia, and you don't know if it's a MGUS or not. So I don't see how you're going to get away without a bone marrow biopsy. Let's say you do the bone marrow biopsy and you see myeloma. That's the real question. Do you need to then follow up with a renal biopsy?
Well, you just said something interesting to me, and I'm trying to figure out where this came from. Why do you think this would even show membranous? Or you're just using that as an example?
Oh, no reason. I'm just saying we don't know. Right now what we have is renal disease and a paraproteinemia is what we have, with a high total protein.
And an acute kidney injury.
And relatively acute kidney injury, yeah.
Well, it's gone from 0.9 to 3.4. That's pretty significant.
So let me then answer my question. Let's say we do a bone marrow biopsy first, and it looks like myeloma. What is the renal biopsy going to add to you? Why, if you find myeloma and you know there's a myeloma protocol that's going to be treated, this is a common question. In fact, there was a whole study that was in the last couple of years, and Nelson Lung wrote an editorial on this very topic. If you have myeloma, do you need a renal biopsy if you've made that diagnosis?
Well, like I said, I think I said this when I was explaining it before, is I think it'll give you at least some insight, especially with this guy's renal function getting so much worse, as to how much chronic versus acute damage there is, which might give you some insight in what to expect as far as recovery.
And is that worth the risk of a biopsy?
Well, okay, now we get into that whole discussion.
No, but it's not.
Let me finish.
It's a big deal.
Well, if it's that high of a risk to do the biopsy in the first place, then by all means do the bone marrow and then see where it goes. If the feeling is that he's too high a risk for a renal biopsy, but assuming that most patients aren't a high risk, I don't think there's that high of a risk of doing a biopsy in somebody like this who has otherwise normal sized kidneys. Anyway,
Let me ask Dr. Glassick. I know you started a little late, but it's a simple question I'm asking. That is, if you have a patient like this and you did a bone marrow and it fulfilled the diagnosis of multiple myeloma, do you still think the patient should have a renal biopsy? Dick, are you on?
I think he's muted.
Thanks, Roger. I'm sorry I came late. I would do a bone marrow biopsy first, and if it shows myeloma, I wouldn't do a kidney biopsy.
See, that's kind of my thought, but as I said, even Nelson Lung kind of made the argument in his editorial a couple years ago to doing that. I just don't see that you do a renal biopsy. It's not going to change your therapy. The prognosis it'd be nice to know. There's a lot of things that'd be nice to know. We may get back this later. I may ask Dr. Gashty if he knows any more about this concept. Okay, well, I think I've beaten that. Unless anybody else has any strong opinions on that.
What did Nelson say? I can't pinpoint the editorial.
What did what?
What did Nelson Long say?
Well, you know what? I'll ask Casey to tell you that because I think he looked at that article when he discusses the case. I'll have Dr. Gashty kind of go over that because I think he just recently read it.
He was advocating for doing a biopsy for a couple of reasons, which I, to be honest, personally found to be weak arguments for it. But one was the coexistence of multiple lesions on a biopsy. And again, that would be really more prognostic as opposed to changing management. So let's say if you have cast nephropathy, it would be rare, plus something else, amyloid or something, then you would at least have this sense of maybe the proteinuria would not go down if you treat or something like that. So, that was, basically one argument was you may find something else besides a myeloma related or a paraprotein related lesion. He brought up the issue of safety and how previously it was thought that some of these patients were high risk for bleeds because of the amyloid and vascular amyloid and bleeds, and that has been debunked by now. That at least the study that he quoted, 70 patients, none of them bled. So the safety issue was no longer in play. At least safety of biopsying a myeloma patient versus a non-myeloma. Now, anemia by itself could be a risk factor, and some of these myeloma patients are anemic, but at least the amyloid aspect of things did not, at least in that study of 70 people, did not add any risk. So he was, like Steve Corbett said, he was basically saying, it was for prognostication and also, just in case that there is other lesions beyond a paraprotein related.
yeah, I mean, you bring up a good point. I mean, I don't know how frequent it happens with amyloid where you have, a coexisting cast nephropathy, but for sure with light chain deposition disease, cast nephropathy can coexist in about 25 to 30% of cases. And in those patients, again, it's, as you said, and I alluded to before, it's strictly prognostic, because if you have cast nephropathy, your potential for having any major recovery in renal function is not real good.
Also, amyloid occasionally with cast nephropathy occasionally.
No, yeah, it is. But like I say, light chain deposition disease with cast nephropathy coexisting is where I've seen it written the most. But anyway.
All right, let's see what we got. Well, obviously the answer is we did a renal biopsy first, after all that.
Well, I thought maybe you're going to show a bone marrow biopsy and we were going to read that.
No, we're looking at renal biopsy. Comes to a nephrologist, we do a renal biopsy.
Okay.
Dr. Whittier, who is in the airport or on a plane right now, so that means it's going to go to Dr. Height, because that's always the default fellow. Please go to Steve. Okay.
Oh, Bhavna.
Bhavna. We didn't even
I was
have to
gonna go to me.
Rig
So close.
the wheel for Bhavna today.
One click away from Premier.
I know. Would have just shut down the Zoom and said it was a IT error. All right, Bob. Now I'm going to give you control here. Give me a second. Can you try out your microphone? I can't hear you yet. Try to unmute yourself. Unmuted. Can't hear you. Still can't hear you. Are you with Steve? Oh, you're separate.
Well, it sounds like it's going to Prevere to read.
Yep, I can read it. That's okay. I'll read it. You owe me, Bhavna.
I know what she's doing. She's doing this.
No, she's trying. No, she's unmuted.
You don't want to read it,
There's
so
there's some
she's
error.
pretending like her microphone's not working. We still
All
love
right.
you, Bob.
All right. So here we go. See, I put that in there just in case it went to Bhavna. So that's my fault. All right. So David, you on?
Yeah, can you hear me?
Okay, good. Yep. So low power trichome stain. This creatinine, if I remember, it had been up for at least 9 months. So, there's always a possibility of some chronic fibrosis and disease. I mean, there are some areas, I mean, you see some glomeruli here. So it's a good sample. There's some areas, I would say very patchy. I don't know, David, 10 to 20%.
Yeah,
Okay.
yeah. It was just kind of mild.
Yeah. Is this more medulla over here or no? Or
No,
that's
they look like proximal tubules.
proximal
I think
tubules,
that's
okay.
cortex. Yeah.
So you have some good glomeruli in the sample, which again we'll look at a higher power. Of course, calciferopathy was on differential. Sometimes we can, at this power see some of that. Well, again, can't comment on it, but we'll see as we get closer.
Yeah. It certainly doesn't look like any tubular casts
No,
jumping out to us.
no, not like at least diffusely.
Yeah.
Oops. Okay, so this is high power. Let's look at this. This is PAS.
H&E stain.
Sorry, I mean H&E.
Yep.
H&E. I was looking at the tubules. I didn't see it. I was going to say H. So this is H&E stain. You have one glomerulus here, kind of right at the edge. Kind of looking at it, you see, again, our differential primarily dealt with paraprotein related lesions. I'm looking for areas of kind of almost amorphous material depositing. But if you just look, some of these loops are hard to see. They are open here. There's no crescents or anything of that sort. But maybe there are some areas where there's
What strikes me is
mesangium.
the mesangium is very eosinophilic.
Yeah.
And it's kind of expanded throughout to a moderate degree.
Mm-hmm. Yeah, it's primarily mesangial.
Yeah.
But very quite expanded to the point where yeah.
What about the
and
interstitium?
interstitium? This is an artery, right?
Yeah.
And I don't see many. We have some tubules here. There looks like some those look some spacing. The tubules are not back to back. And
No, but up above that artery, there's some pinkish looking material. Right
Yeah.
by the distal
above the
tubule.
artery, over here, right there.
Yep.
Yeah.
Yeah.
There looks like definitely something going on in the interstitium in terms of deposition, very similar. So
Yeah.
again, paraprotein, light chain deposition, things of that sort, amyloid.
Call it nodular.
Not really. I mean, this may be a little, but no.
Yeah, I agree with Prevere. I would not use the word nodular.
Yeah. Now this is our PAS. We have one glomerulus on the screen here. So looking at the glom, this looks like the hilum here, David, right?
Yeah.
It's interesting here. I'm not seeing much in the mesangium in terms of deposition.
But if you go down to the hilum, it's that material, in that area. It looks
you'd
kind
say,
of
I mean, it's weekly PAS
positive, yeah, kind of
and
amorphous.
so it's hard. So if it was just, but in general, in the hilum, it should be the same intensity as your GBM otherwise, right? So this is a little lighter. So you're saying this is maybe just more deposits?
Yeah. I think there's deposits here in the perihilar area.
Okay.
That are weakly positive.
Mm-hmm. So that kind of goes along with what we see in amyloid. Again, we'll see more stains, but weakly positive, weak PAS staining. In terms of the tubules, you can see proximal tubule. You see the brush borders. Not seeing much of ATN here. I mean,
yeah. Yeah, tubules look good in
Yeah,
this.
very good.
Yeah.
And I don't see any interstitial. These tubules actually look back to back without any.
Yeah.
But I guess we'll keep moving forward. So some perihilar deposition of weekly PAS material. Otherwise, the glomerulus, it looks pretty normal.
Now, let me ask you something. Why did Roger bring up the possibility of nodular changes?
So nodular changes, we see that. So in terms of nodular differential, so of course, paraprotein, light chain deposition, amyloid, diabetes, which this patient did not have, and also idiopathic nodular sclerosis, all would be on your differential for nodular appearing. And again, we would expect a little more proteinuria with that deposition, but again, so I think that's light chain and heavy chain deposition. Those will all be part of your paraprotein spectrum of lesions.
Right.
This is our Jones stain, looking at one glomerulus kind of filling the entire screen. So we did see that weekly PAS material, so I'm kind of honing in on, sometimes an amyloid. We see this coxcomb or kind of a thing that looks like spikes, but in general, the basement membranes are intact. I don't see any breaks or anything like that.
Yeah, I agree. They look smooth.
Smooth. I'm really searching and nothing's popping up
Yeah.
to me. Maybe here, but I'm probably overreading that. This looks pretty normal to me.
Yeah.
Okay. Interstitium. This is a H&E stain. I'm sorry, H&E stain. Looking at the interstitium. Let's see. Tubules. You have a lot of interstitial infiltrate right here.
Yeah.
Some of those look like at this power eosinophils almost.
Yeah. We'll go to higher power on
Yeah.
the next image, but yeah, focally dense infiltrates.
Lymph, it looks like, and we'll see what type of cells. Definitely some EOs, but these tubules, again, as we saw in the low power, I don't see any, cast. This may be a hyaline cast, but I don't.
Yeah, those are just
Yeah.
Tam-Harslow protein.
Yeah. Higher power interstitium.
Can you go back, Pravir? I'm sorry, I
Oh no,
can't-
not a problem. Go ahead.
in the teaching mode today. Why aren't those myeloma casts?
Great point. So the myeloma casts, classically, they'll have this fractured appearance due to the processing, and they're more fragile because they're light chains, right? So if they're made up of light chains, this is more Tam-Harslow protein. So they classically had this kind of fractured appearance, and this should be a little more eosinophilic, right?
Yeah, very good, Pravir. Yeah, they're also associated with giant cell reaction as well. Yeah,
I
none of those
reviewed my
features are
notes
seen
from
here.
fellowship right before.
Yeah.
So this is that focal infiltrate that we had. Looking at the cells again, these are eosinophils. The rest of them look like more lymphocytes.
Yeah.
Okay. This is a tubule. It's interesting. It looks like I don't know, what is this?
I think it's
normal?
atrophic. That's
Okay.
a thickened basement membrane.
Okay.
Yeah.
Up on 12 o'clock, there are a few plasma cells.
Yep.
Oh, plasma cells.
Yep.
Okay. Okay. I don't remember the patient was. We'll review the med history, but eosinophil again alludes to
Just
some
multivitamins
multivitamins.
and Zantac PRN.
Zantac PRN. Usually those are not associated with a drug-induced or hypersensitivity acute interstitial nephritis, but who knows? This is PAS stain, again, looking at the tubules. There's some atrophy here, right? Some atrophic tubules over here.
Why are you saying that?
Some of this, the wrinkling of the basement membrane, the tubular membrane, kind of looks a little shriveled.
Yeah, and the tubules
So,
are shrunken and atrophic.
Shrunken,
I
atrophic
agree with
appearance
you.
here.
Yeah.
Maybe some ATN here. Brush border not as clear.
Yeah.
And then there's this, I don't know if this is in the center of the screen, usually a hint, or this is just.
Yeah, more ATN, sloughing of epithelium, loss of
Yeah.
brush borders. Yeah.
So we have AIN, ATN as well that we've seen.
Granular cast in the middle.
Oh yeah. Another PAS stain.
So in this area, Pravir, yeah,
Is this distal tubules?
no, that these, yeah, we're getting into the medulla here, but these deposits were really striking. Look between the tubules. You
Oh,
had
wow.
these
A lot of space.
amorphous type deposits and surrounding the tubules as well. Yeah.
Okay.
very eosinophilic.
Mm-hmm. So Congo red is negative.
This is negative.
Yeah, negative. Usually it's positive, but it's negative here. It's good.
Yeah.
You have a vessel here, and one glomerulus here, and you can see that those deposits that we had maybe in the interstitium, none of them are popping up. So negative Congo red, which for amyloid we test for, so that's negative. So the next would be immunofluorescence. So I'm assuming this is kappa. So kappa is lighting up both glomerular and tubal membrane. Then we want to see the lambda comparison to see light chain restriction, which we do have. So there is a kappa restricted chain. The next is to see if there's any other immunoglobulin heavy chain restriction. And I guess that's what this is, IgA.
Yeah.
But for the rest,
It was
negative?
positive.
Only IgA positive.
Yeah.
Oh, you had an IgA kappa restriction.
Yep.
Within the glomerulus and the glomeruli here, and then also the tubular the interstitial space.
Yep.
To the EM, kind of orienting ourselves. Let's see. This is urinary space. This is the blood space. No, following the deposits, I don't see many deposits at this level. And again, based on the
Okay,
light.
yeah. So to find them, Pravir, go straight up. Yeah, and to the right a little bit. They're on the inside of the basement membrane. Yeah. So those are aggregate. They're aggregated into cluster dense deposits.
Wow.
And there's also some powdery deposits just to the left of those.
Oh, right here.
there, along the basement membrane. Yeah.
Yeah. Some more of the same here. Some deposits with.
Yeah, so these are again
Ton.
granular deposits aggregated into cluster dense granules, and then on the right you could see they're on the subendothelial side.
subendothelial
Yeah,
space.
right there. Yeah.
Some more of the same.
And this is a tubular basement membrane. The interstitiums off to the left. Yeah, so you could see them powdery granular deposits along tubular basement membranes.
Powdery granular deposits, both in the interstitium and the glomeruli.
Can you go back a couple slides?
Mm-hmm.
So David, this is what is it, glomerulus?
Yeah. This is like a mesangial cell. The deposits have clustered.
Oh, it's very high power. Okay.
Yeah.
It's very interesting.
They're so round. Is that typical?
Yeah. This is typical for monoclonal immunoglobulin deposition disease. They aggregate.
Yeah, but
and they become clustered.
I've never seen them that dense.
Dark. Yeah, that dense.
Yeah. This is the first case I've seen it this obvious. I referred to the textbook and saw this type of description.
Oh, interesting. I mean, the powdery is really there on the right side.
Yeah, right here.
Sub endothelial area, but I didn't know what was going on here. These little cannonballs. It's very interesting.
Yeah.
They're not crystals, right? It's not crystalline. It's just round deposits.
No. They like I said, they aggregate into and become clustered dense granules.
And you saw a picture of this in Hiptonstall or something?
Yeah.
Wow.
Now, the powdery appearance is characteristic of light chain deposition disease, isn't it?
Absolutely.
Yeah.
David, can you go back the last EM slide? On the right of the basement membrane, what are those fibro-looking things?
Collagen fibers.
Oh,
Where is that? Where is that?
I'm not sure. I'd have to zoom out and see. I'd
They
have to
look
see
like-
it at a lower power.
Okay.
So did you see the same granular deposits along the glomerular basement membranes? Because they lit up pretty strongly too with the light.
Yeah,
chain.
right there.
Right there. Okay.
Why would there be collagen where there is no basement membrane?
Due to scar fibrosis.
Okay.
Yeah.
So the final diagnosis here would be, so you get IgA kappa, so IgA kappa, heavy and light chain, right? So heavy and light chain deposition disease with ATN and AIN.
Yeah.
Okay.
So David, just to clarify, if this was just pure light chain, the IgA wouldn't have lit up in the glomeruli and the tubules?
Right.
Okay.
But it didn't light. It's interesting. It didn't light up anywhere nearly as positive as the kappa did.
Right.
Strong, it was pretty strong in the tubules, but not as much in the
Yeah.
glomeruli, if I remember.
Yeah.
Yeah, you're right. But even there, I mean, if you compare the two, I mean, the kappa lit up like a Christmas tree everywhere. I mean,
Yeah.
that was pretty impressive.
Yeah, that's an excellent point.
So, Steve, what are you surprised?
I totally am surprised.
I mean, you kind of called it. I mean, you thought, you know.
Of course I did. I had everything in my differential.
Oh, no, but I mean, you know, the only thing that bothered you for LCDD or heavy chain, you know, it's funny that we talk about light chain, we almost never talk about heavy chain. I don't, because it seems to be so rare, but that it's more glomerular and you expect a lot more proteinuria, you know. And I think
with
that's
either one
valid.
of them, right? I mean, I am amazed that, I mean, the albuminuria was, the microalbuminuria was normal, essentially 30 milligram per gram or whatever.
Yeah.
I mean, usually these patients come in with, you know, significant proteinuria. This person's developing progressive renal disease. Now, I don't know what percent were globally sclerosed, David.
Before that, it looked a lot more interstitial involvement so far than the glomeruli.
Well, I mean, the way it lit
That
up,
may be why.
the way it lit up, it was both. I mean, the glomeruli lit up just as much as the interstitium did. You don't always have to have nodular disease. In fact, the patients that have cast nephropathy associated with light chain disease usually don't have nodules, and they usually progress to renal failure a lot faster as well. But there, you know, as you pointed out, Treveri, when you read it so nicely, there were no casts. So I don't know what else. You're right. So there's clearly the renal, the progressive renal disease appears to be more tubular interstitial, but I still can't, you know, reconcile this whole issue of almost no proteinuria whatsoever. I just find that fascinating.
And I guess, you know, you could say, well, a lot of the renal failure could have been from the AIN and the ATN, and maybe time will tell us the response to therapy where he ends up. I think I want to hand it back to Casey because I think he's got some slides to go over on this. Casey?
Okay, Casey, I'm going to give you control here. Give me a second. Go for it. You can click. Yep.
All right, so I just wanted to give you some follow-up on the patient. So the patient did undergo a bone marrow biopsy the next day after his kidney biopsy, but the results of the bone marrow take much longer. So by the time he came back, the patient had 30% plasma cells. So plasma cell myeloma involving 30% of the cells with an interstitial pattern with a background myeloreduced hematopoiesis. And then skeletal survey, there were a few small areas of lucencies around the pubic ramus, left and right side both. So so there were some lesions on the bone, and the biopsy showed multiple myeloma. So hematology took over at this point and started the patient on a regimen of Cybor-D. I don't know who keeps advancing. Okay.
Go for it now. Click on this. Yep, you know, go ahead.
All right. Cybor-D as inpatient, and then the patient was discharged and daratumumab was added. So I have sort of a follow-up as far as the quantitative immunoglobulins and also the kappa and lambda. So he did respond. His IgA level hasn't really gone down very much, but the absolute kappa is, you know, went from 42 to 22. The ratio has really not changed that much because lambda was also gotten suppressed. So overall, you know, they feel that they're trending in the right direction, but the response after about 3 months of therapy has not been as adequate. So his creatinine, fortunately, did come down. So to be completely transparent, I did actually put him on a little bit of prednisone right away because I saw some interstitial nephritis. Wasn't sure what that was about. Hematology was okay with that. So that some of that may be ATN resolved, some of that may be interstitial nephritis treatment. But so the creatinine came down from a peak of about 4.5 down to about 2.5, and it's essentially remained around that area since he's going through his myeloma treatment. So as of right now, he was referred to the bone marrow transplant team for an auto stem cell transplant, but they did not think that he was a candidate at this point because he has not reached a good enough response, clinical response, because the definition of response from a myeloma standpoint is in partial remission would be 50% reduction in M protein, and the patient has only gone from 1.5 milligrams per deciliter to 0.9 IgA kappa. So has not even reached a partial response, let alone a very good partial response, complete response, or a sustained complete response. So once he reaches one of these, then that would most likely, he would be a candidate for that. He's young, he's very healthy. He does not have cardiac involvement based on the cardiac workup, so that they are considering him for transplant. They just need to see a better response. So
Casey,
they actually went ahead and added Cytoxan. Go ahead.
was the DARA, is that kind of routine now, or was that added because he wasn't seem to be responding?
No, the DARA was part of the initial treatment.
So they really attacked this thing.
Yeah, they added Cybo-D and daratumumab. Yeah, they attacked it, and I'm not really sure why he hasn't responded. I don't know if what their predictors are, but I'm not surprised that his creatinine is not normal because of all the things that we saw in the biopsy. But from a hematological standpoint, they're going to go for another month. They're going to repeat a bone marrow and see what the plasma cell response has been, what the flow shows, and so it may take a little bit longer. So some of these things don't respond right away, but so they continue the treatment for now.
I was under the impression they follow the kappa lambda ratio and look for a 50% reduction there. Is that not the case, or?
They look at that as well, and he hasn't. So here's the kappa lambda ratio. So he hasn't really responded per se to the ratio. But if you look at the absolute kappa level, his lambda has gone down to 0.4. So the ratio looks about the same, but both kappa and lambda are lower.
Yeah.
So they, basically, if you look at the absolute kappa, he hasn't reached 50% response. If you look at the ratio, he hasn't really responded at all. So
no, I was just wondering. I realized that. I don't know why I thought in the stuff that I'd read that they were, since it's much more sensitive at picking up the light chains than a serum immunofixation. I just assumed they were following that now more closely.
Well, I assume also the fact that his renal function got a little bit better has something to do with maybe the lambda going down a little bit.
That's true.
So there were a few questions for me. One was, the whole issue of biopsy and when to do a kidney biopsy. And one of the things that I found that is very helpful is if the patient already has a hematological diagnosis, I think that changes your likelihood of thinking about a kidney biopsy. So this was a study from out of Germany, about 178 patients, and they had divided them into what their original hematological diagnosis was. Of that population, about 70 of them already had established multiple myeloma, and for one reason or another, they underwent a kidney biopsy. And that about 40 of them, so almost 60% of them had cast nephropathy, and then the rest were sort of like a hodgepodge of amyloidosis and light chain deposition and some of the other C3GN and cryos and things like that. If the patient had NOD, stands for no oncological diagnosis, so this is something that we see sometimes, that the patient comes to us like this patient and we find something we're not really sure. If these patients get biopsied, then it's a 50-50 between cast nephropathy and amyloidosis. Light chain deposition is still quite rare. And in general, light chain deposition is very rare when you compare that to cast nephropathy or amyloidosis when it comes to paraprotein-related kidney diseases anyway. And if the patient has MGUS and they get biopsied, then you really kind of like the differential opens up to, it could be anything. In fact, half of the patients who get biopsied and they have a paraprotein in the blood don't even have anything related to this. And I think this was previously published, by the Vanderbilt group. So this is kind of helpful. So as was mentioned earlier, if the patient has a diagnosis of myeloma, they're going to go through the treatment. I may skip a kidney biopsy. If the patient has MGUS with some indication like a renal insufficiency, I am more likely to biopsy. I am definitely going to biopsy because that may actually push the patient from a not treatment to a treatment group. And then there's this not oncological diagnosis. Obviously, once you do a kidney biopsy, this group goes away. They either move into myeloma or they move into MGUS, myeloma/MGRS. So I thought that was interesting. As I mentioned, light chain deposition is rare, but if you look at it, 80% of all monoclonal immunoglobulin depositions are light chain. And then of that, 10% are light and heavy chain, and 10% are heavy chain deposition disease. The vast majority of light chain deposition diseases are kappa, 80%, unlike amyloid, which is predominantly lambda. So one of the clues, I think, in the history would have been kappa being high, maybe light chain is more common than amyloid. So that was sort of a clue. And one of the things that I still don't really kind of understand is, what makes these light chains actually stick and congregate. And there are a bunch of very technical papers that look at the various biochemical characteristics of these light chains, site-specific amino acids, net charge of the protein, and things like that. And essentially, that kind of determines how the light chains aggregate into either deposits, or they form fibrils and become amyloid. So one way versus the other has really to do with the biochemical characteristic, and that's what determines toxicity. This is still an area that is still kind of being worked on. But one of the interesting things with heavy chain disease is that there are some identified deletions in the heavy chain that predisposes it to tissue deposition. And the most prominent one is the CH1 domain of heavy chain. So there is a disease called heavy chain disorder, which is not the same thing as heavy chain deposition disease. Heavy chain disorder is a production of abnormal production of heavy chain by plasma cells, but these patients have heavy chain elevation in the blood, but there is no tissue deposition. In those patients, the heavy chain has a normal CH1 component, whereas in the vast majority of patients who have heavy chain or light and heavy chain deposition disease, the CH1 domain of the heavy chain is missing. So that's a clue that there are these structural differences in what's normal and deposits and what's abnormal that doesn't deposit. So those are some of the questions I had about this case. The patient, unfortunately, the kidney function is better. Hematological response is subpar, so continue treatment and look for a response, and hopefully he gets to a transplant. But that's kind of what I have.
And Dr. Reen made the point that IgA myeloma carries a much worse prognosis, which I didn't quite realize. But to me, this patient's not doing great. I mean, he's got things have really changed since the old days of melphalan and prednisone or whatever we used to use, and now we've got bortezomib. It's been around a while, but that was a huge game changer. And Dara is highly effective against plasma cells as well. So far he's gotten both of this and hasn't had a great response. Mario, you want to explain the FISH test for me?
Well, it stands for fluorescent in situ hybridization. And basically what it is a specific type of genetic test that looks for genetic abnormalities in the plasma cells in the bone marrow. And according to whatever the findings may be, it has diagnostic, prognostic, and treatment connotations. I think that you can classify patients the way I understand it into high risk, intermediate, and standard risk, depending upon the findings on the FISH test. I think that's the extent of my knowledge with it. But I think nowadays it's part and parcel of the workup of patients with myeloma.
Yeah, I've seen it. I haven't really looked into it, so I appreciate that. Didn't know if it was just a diagnostic or both a prognostic, and I see your point. Before we wrap this up, I want to go over something here. I've been trying to deal with this question for a long time. And so I kind of asked around my group to see why they thought the kappa lambda ratio increases in CKD. And I got a lot of different answers, and my answer was also, different. I remember I looked it up a while ago, but couldn't really put it together. So it's kind of an interesting phenomenon here. So I want to walk everybody through it. So first of all, kappa light chain production is 2 times the lambda light chain production. Next. So free kappa should be greater than the lambda, which is, I'll get to that in a second. Now, the level of anything in the blood has to do with the production and the clearance. So if kappa is produced twice as much as lambda and the clearance is the same, then the kappa level should be it should be twice that. But the problem is that lambda, actually on the right here, you can see the dimer. So these are the molecular weights of kappa and lambda. So 25 Dalton can kind of get, a little bit can get through. At 50, you're starting to get a pretty big molecule. You're going to have size restriction. Forget about charge restriction, you're going to have size restriction. So because lambda is a dimer, next, renal clearance is going to be a lot less than kappa renal clearance. The renal clearance of lambda is a lot less than kappa. So even though kappa is made twice as much, the fact that the lambda is so poorly cleared, lambda levels are greater than kappa levels. And next, what that gives us is that even though the ratio, the normal ratio and a normal of kappa lambda free chain light chain ratio is a huge range from 0.6 to 1.65, at least the median is 0.58. So the median kappa lambda ratio is less than 1, even though kappa is produced twice as much because lambda is so poorly cleared. However, in renal failure, the renal clearance is no longer the predominant way that you get rid of light chains. It's the reticuloendothelial system kicks in, and the majority of it is being removed by the RES system. And it removes them equally. So now you got kind of forget about the kidney, and now we're back to the point where you make twice as much kappa than lambda, but the same removal. Right. And if that's the case, then the kappa ratio is going to go up. And so that's why in CKD that now the ratio becomes a higher number. Now it's still a huge range. Next slide, or next. Yeah, it's still a huge range, but compared to the range of 0.6 to 0.26 to 1.65, almost the higher end can even double. And so it's really kind of a couple phenomena going on. The fact that it's a dimer, it's poorly renally cleared, but at some point with renal failure, the renal function plays no role into it. Now I got to say that these numbers have made a lot. They've made a lot of these numbers. In fact, there's an article in Blood. I didn't put the slide here where the normal ratios they've now tweaked it down to the level of CKD, and it changes with the level of CKD. But I don't know personally, if I saw a ratio in renal failure of 4-to-1, which is outside of the normal, that I'm going to really be that alarmed. Of course, I'd work it up, but I think it's more common when we see a paraproteinemia that's really clinically relevant. It's not in these really small ranges. It's a much higher number, but I can't be sure of that. But I've been struggling with this for a while, so it was fun to read through it and kind of figure out what the reason is for this increase in ratio. With that, I think we're going to wrap this up. Our CME code is 491821. I think normally we go every 2 weeks, but Dr. Bexley is going to be gone in 2 weeks. So we'll be back in 3 weeks. Either way, we'll send you an email. And until then, everybody stay safe. And thanks for all the input.